doing DAs and doing DAs with robots. So how safe is it? So we'll just see what basically I'm talking about. So THR has been one of the most successful surgeries in orthopedics since its popularization since 1960s. We all are aiming to get the perfect implant placement, perfect alignment, perfect limb length discrepancies, to avoid any limb length discrepancies, and to get the patient back to his foot as early as possible with minimal pain and earlier functional recovery. So the need for THR is increasing because of COVID pandemic we had. There are a lot of patients, a lot of young and active patients who are coming to us for surgeries. A lot of bilateral AVNs we are seeing. And the main target for all of us is to reduce or shorten the recovery time and to place the implant accurately so that the patient has good functional outcome without any complications like dislocation or limb length discrepancy. So the hip now can be approached through so many approaches. We all know there's like a 360-degree approach to the hip. What we most commonly use is posterolateral, then direct lateral, anterolateral, and direct anterior. So I am a posterior surgeon. I was a posterior surgeon, so I've just crossed the line maybe 3 years back, and I've now started doing most of my surgeries through anterior approach. Now coming to why I shifted. Conventional THR provides very good, posterior approach provides very good exposure to the joint. It's easier to perform than the anterior approach. Then why change? Why change? Because it's like falling from a skydive. So you don't know where you will land at the end of the surgery. Most of the surgeons, even the best of the surgeons, have incidences, very rare incidences in which they have not put the implant in the right position. And they themselves know that no, this one thing is not went right today. So to avoid this is one of the reasons jumping to anterior approach. And limb length discrepancy being one of the most common causes in any other approach than anterior. If you're doing it conventionally, limb length discrepancies are very common with any other approach because the patient is lying on lateral position. And also there's a chance of dislocation, there's sciatic nerve palsy risk, and also component malposition. So all these factors actually were bothering me, and I wanted to start doing anterior approach. So why DA? Because also the patient is very comfortable in surgery. The patient is lying on his back. There's minimal discomfort, and most of it, my anesthesia is also very comfortable because in case if the surgery gets prolonged or due to some other reason, the plan of anesthesia changes, they can easily put in a tube and the patient can be put under GA. And also one of the reasons is DA being an internervous plane, so there's no, it's intermuscular plane, there's no need to cut any muscle. You just have to cut the fascia and you're at the hip, anterior capsule, and it's very simple. While doing any other approach, you are going intramuscular or you're cutting various muscles, you're cutting the rotators, and then you're trying to repair. There's a chance of dislocation, and there's a chance of other injuries like neurovascular injury. So conventional THR by anterior approach is a muscle sparing approach. There's a smaller incision, there's faster recovery, and offers less exposure. So the only pitfall is offers very less exposure of the joint. So you're looking through a very narrow window. So why now moving from conventional DAs to robotic DA? Pitfalls for conventional DA is the incision is very small. So you're looking through a very smaller window, and you might struggle while placing the implant or the acetabular exposure. And there's a need for special instruments and table. There's also a risk of implant malposition if you're not doing under a fluoroscopy guidance. There's also a higher learning curve, and there are complications like wound complications or trochanteric fractures which can happen in the early stages. So what are the methods to improve THRs when you're doing it through anterior approach? One is to do an intraoperative fluoroscopy. You can take C-arm shoots. So whatever position, if the patient is you're doing through a posterolateral approach or posterior, the patient is lying lateral, you can take C-arm, but it's a little inconvenient every time to pass in the C-arm, take shoots, and it's difficult. The other way is to use computer navigation, and lastly now to use robotic arm assisted guidance. So conventional DA, you can actually, when you're doing a supine, the patient is supine, you're doing a THR through anterior approach, you can actually position the implant and check under C-arm. You can check the offset and limb length discrepancy also. So I'm just sharing a few x-rays. So here you see, before putting the final implant, I'm taking a trial. I'm seeing how my version is, how the screws are looking. I'm broaching and putting a trial broaching, seeing whether it's in the center, how the things are. And this is the X-ray which you get before you shift out the patient in the OT. And this is the final implant which you put. So you can actually check every step while you're doing an anterior approach, and you can get exactly identical results, especially when you're doing a bilateral hip. You can match the offset, you can match the horizontal and vertical offset, you can get the exact length, you can get perfect implant placement. And you can also see where your screws are going, you're not going intra-pelvic. So the need for robotics in THR, so why to change to a robotic DA when you're already a conventional DA is very good. So the main idea is to reduce the incidence of LLD. Some amount of LLD can still happen with the supine normal conventional approach. To avoid that, you can use robotics, and also the acetabular cup inclination and anteversion can be perfectly aligned when you're using robotics. You can also restore the global offset and the center of rotation of the hip, which you cannot do it when you're doing conventionally. And you can manage acetabular defects. You can also manage spinopelvic deformities. So this is very important. So robotics, this is the only robo which is available, which is doing a total hip with full implant placement, and also it guides you with the version and everything. So coming to three components of robotic THR, what is more important is the acetabular cup placement. You can exactly plan how much anteversion you want, how much inclination you want, and you can execute it to the T. So, so that's how it is. Robotics is playing a very important role. So here you see if you're impinging or your cup is anterior, you can push it more inside, you can medialize it, you can put it inside, and you can exactly match what you're desiring. And also what's more important is the stem anteversion and alignment. You can get the perfect alignment with the stem. You can see how much neck cut you want to do, and you can try and match your offsets exactly as you're planning. And one more important thing which you cannot do in conventional DA is you cannot check for impingement. While in robotics, it will tell you the exact location and at how much flexion and extension is it impinging, and then you can modify your plan to avoid impingement. So that's how robotics helps in making good things better. So also, what is more important is limb length discrepancy. I'll be giving another talk on this with robotics, how it is important. And you can exactly match your plan. You can exactly match the opposite hip in terms of, you can get as close to a millimeter in terms of the limb length discrepancy. So advantage of robotics is it helps in accurate placement of components, it reduces the chance of dislocation, and it also helps in restoration of global offset. So all these three are making DAs more and more comfortable for the surgeons and giving more accurate results. With robotics, you can also do DA in femoral rotation deformities, narrow femoral canal, varus necks, acetabular defects, dysplastic hips, and also you can do revision THRs. Thank you.